Okay, good afternoon and welcome to today's webinar, Side A, Press Play for Intensive IDT Training, Building the Basics, presented by QRM. QRM is an in-house rehab management company that works with skilled nursing facilities all across the country. We also provide MDS education and training, medical review, compliance assistance, and marketing services. Visit qrmhealth.com to discover more about our services. My name is Amy, and I will be your moderator for this session. So now I would like to introduce you to our two presenters for today. First, we have Mark Heider, VP of Reimbursement Strategy and Education for QRM. Mark has 30 years of experience in the skilled nursing space and a deep understanding of the challenges and intricacies facing our industry today. He is passionate about educating the next generation of healthcare leaders and is committed to improving patient care and operational efficiencies in the facilities we support here at QRM. Next, we have Megan Ussery, Director of Clinical Reimbursement for QRM. With over 15 years of experience, Megan is dedicated to post-acute care with a particular focus on reimbursement and quality. Her expertise lies in utilizing MDS data trends and outcomes to guide process development and education for clients that QRM supports. During today's webinar, Mark and Megan will highlight everything that you need to know to build a successful strategy, as well as discuss the final rule and its potential impact on your SNF's overall clinical and financial outcomes. So as I wrap up, I just want to thank you again for joining us today. We're very excited to have you here, and we hope that you find this webinar informative and engaging. Just remember, this will be available on demand on the QRM website within 24 hours, and submit your questions in the chat area at the bottom of the page. Thank you. Now I'll pass it off to Mark, who will get us started.
Thank you, Amy. Appreciate it. It's a beautiful day here in Texas. You ready for this, Megan?
I am. It's hot. It's beautiful, but it's hot.
It is beautiful. It's hot. So really excited that you joined us again. For those of you who attended our earlier webinars, some of these slides will look familiar. So let's talk about that for just a minute. Some of them will look familiar, but really our strategy is to make sure that we're presenting the information. And when we get to this point of the year, we kind of know it's go time. We have from mid-August to October 1st to make sure that people are implementing the changes that we've taught. So we will be talking about some of the similar items. Most of those, in fact, all of them were finalized just a couple weeks ago through CMS. But just want you to understand that is part of the strategy. And really today is about what are you doing with these items? So we've kind of boiled down the agenda. Let's see if I get this agenda to move. There we go. And we're going to talk about a few items today because we want you to understand them with enough depth, with enough detail to really implement. And again, question yourself, because we're going to question, what are you doing with this information? Very important to us that it's useful information. You're doing something with it. The other side of it is, quite frankly, if you want to stay in business, you have to learn this information. You have to use this information because there are consequences to not following the rules, to not understanding how to implement these changes. So please, like Amy said, enter your questions below. If we don't have time today, we will do a Q&A and we'll follow up. We'll send that document out. A lot of times there's not time at the end because I don't know about Megan, but I'm kind of long-winded. So we'll go on and we'll talk a lot about these things, and we'll make sure that we are thorough enough that you have the detail. And then we'll give you the opportunity to ask questions. Now, tomorrow, we'll be presenting again. And those items that we're not discussing today, that we've left off the agenda today, we'll be going through those. And it really is an IDT approach at making sure that the changes that CMS finalized recently are understood and implemented. That you understand it really is an interdisciplinary approach, as should be the topics that we talk about today. But again, the REI manual was written so that anybody who is adequately trained could follow up and perform the assessments and document the information. So we want to take it from that level. So today we'll talk a little bit about the final rule. We're going to talk quite a bit about the SNF Quality Reporting Program, or QRP. We're going to go through the value-based purchase program changes. And then we'll talk about what comes next. If you're going to flip that tape, for those of you who remember cassette tapes like I do, you're going to flip that tape. What's on the other side? We're going to talk about that. What comes next? And those are the things that are going to set you apart, that are really going to enable you to be successful as you move through the year. And it really, one of the things that I've talked to my team about is we want to make October 1st as eventful as Y2K was. So if you remember Y2K, you're old like me, you stayed up all night waiting for something to happen, computer glitches, power grids to go off, something. And what happened, Megan?
Nothing.
Absolutely
I
nothing.
do remember Y2K.
Absolutely nothing. And nothing happened because people were ready. People had made changes to their systems. Everything was good. That's what we want. That's the type of result we want, is that Y2K type result where October 1st is just another day that you're providing excellent care for your residents and you're going about your business, because the resident care is the important part of what we do. So we're going to start off with a quote. A fresh start isn't a new place, it's a new mindset. I wish I knew the author, couldn't find the author, but you know what? We have the opportunity every day to go into what we're doing and make a change, make a difference. And because all we do is deal with residents, with people who are of value, and the services that we provide are of value, we have the opportunity to make a fresh start every day. And that could be with your team, with your teammates in the facility. It could be with your vendors who you're developing a good relationship with. It could be with the families that walk into your skilled nursing facility. It could be with your residents, and should be with your residents. How are we improving their life day over day? And believe it or not, a lot of the CMS changes really are tuned towards providing better care, to getting better outcomes, to making sure the environments that we're providing are adequate and safe and well-staffed and all those things. So fresh start isn't a new place, it's a new mindset. So let's set our minds ready to really provide better care, to take the changes and implement them so that our teams aren't stressed out, and really focus on what's important. Again, it's our residents.
All right, so we're going to start off with a poll question. Which of the upcoming changes concern you the most? Removal of section G and increased importance on section GG, the move from the PHQ 9 to the PHQ 2 to 9, the new discharge function score, or do they all just scare you?
I'm glad we threw that one in. We're hoping fear isn't a motivator, but you know, we thought it'd be interesting to know, what are the things that concern people the most? Give it a few more seconds. We still see answers coming in. If you haven't answered, answer. This is important stuff. About 40 of you that did not answer.
All right, so as I expected, and sure you too, Mark, removal of section G and increased importance of section GG, more than half, 54% there.
You know, it's interesting though, because you look at the move from PHQ 9 to PHQ 2 to 9, which was our smallest response, only 5 out of 76. That one scares me senseless, because there's so many implications from that. So that is a scary one. New discharge function score, and that's kind of attached to GG.
Mhm.
And here's the thing. We talk about section GG, and we talk about section GG, and we talk about section GG, and people are that's still the number one concern, and rightly so, because it's attached to so many things. Now, fortunately, tomorrow we'll be talking a lot about section GG and section G and what's happened in translation there. So you'll get a good portion of that tomorrow. It's worth looking at, it's worth watching. Glad you participated in the poll. Okay, let's get that out of here. There we go. So we know that CMS released the final rule. It was published on August 7th. There were some changes in it, as there always are. some significant, some not so significant, but it's good to have it. That way we move on. We know exactly what the rules of the game are, and we can really start focusing our efforts and not wasting our efforts on those things that were proposed but not finalized. So let's talk about that. One of the things that was brought up, and in fact, it was the president that talked about it in State of the Union, a year and a half ago, something like that. There's going to be staffing mandates, which scared everybody. So AHCA sent a letter, and they've been working nonstop with the administration. And I've been impressed with the AHCA, American Healthcare Association, and how well they're advocating for us. They really have made sure that the administration, as well as all the other legislators, understand the pressure that's on skilled nursing facilities. And it's crazy the amount of regulation, amount of oversight the skilled nursing facilities get. Not that we don't need oversight, but the amount of oversight is a little bit staggering. So American Healthcare Association has been a huge advocate. Well, this last spring, CMS said that they would be releasing an announcement, about the staffing mandate. I don't know about you, but I waited and I waited and I waited, and spring became summer, and summer is about half over, almost all the way over, actually, for most of us. And there really was no formal announcement that I'm aware of. So it was interesting. That maybe that's good news, maybe it's not good news. But as we'll see in a minute, we do have a staffing measure that's been added to the value-based purchase. So it wasn't unaddressed. There just wasn't a real bold statement saying this is what we're doing and this is the direction we'll take. So lots in the final rule. It's interesting. One of our colleagues said that she reads the final rule every year, but it takes her weeks to get through it. So there's a lot there. There are a lot of question and answers. If you haven't read it, there are responses to a lot of the questions that were posed. So if you do have questions about it, it's great to look it up, and we'll give you that information a little bit later. As many of you know, we have a new MDS that will be effective on October 1st, 2023. We have to be careful, and I think our EMRs are really good about not allowing us to start early with that. But you want to be aware of when that change happens. You want to be aware of what the changes are. We do have a published REI manual with the changes in it, with the proposed, the draft REI, I should say, and it's awaiting, the final version's awaiting release. In fact, it was leaked for a few minutes.
Whoops.
And APAC and a few other people, announced, hey, it's out. And within, I think, minutes, it was gone again. So we're waiting for it, but it will be updated. The thing to do is make sure you're aware of where to find it so that you are using the right references as you're guiding your staff and you're teaching your staff what's going on, because there are many, many, many changes. Not all of them are policy changes, but right now you can go through and get all the red letter changes, which makes it really helpful. These are the items that were changed. Once it goes to the final draft, you won't see the red lettering, and so you won't have that advantage. But again, October 1st, it's very important to be ready for that change. Some of the changes that we saw were language changes. A lot of it is specific to gender sensitivity and socially appropriate language around gender identification. Some, which I really liked, were new examples. And as important as it is to understand the changes themselves in policy and how information is collected and those type things, sometimes it's the examples that are actually the best place to start looking, because they clarify how do we do our jobs, and they put out some really nice scenarios, which I think are helpful.
Yeah, I really like the coding tips, and the examples are always the first place that I go when I'm, looking for some clarification. The coding instructions are helpful, but I think the tips and the examples are my personal favorite.
Oh, you're having a good day when you look through the tips and they have the exact example that you're looking for. That's a good day. Yeah. So I love that. And I don't think enough people read the examples and the tips, the coding tips. We're so busy doing our jobs. The thing we have to remember to do is take a step back and learn how to do our jobs, because quite frankly, it makes your job easier. If you understand the tips and the examples, you know how to do your job more easily, and you're doing it properly. So there are fewer corrections, there are fewer chances to make mistakes, all that stuff. Okay, the next part, elimination of section G. It's one of everybody's fears. We saw it listed on our poll. It's everybody's fear. And there are implications. We'll talk about it several times, especially tomorrow. But one of the things that everybody's thinking is, okay, section G's gone. How does this affect my quality measures when it rolls over to a GG? Because the measures aren't the same, not exactly the same. The other thing is we've put off having our CNAs collect section GG information for 4 years now because we were busy having them collect section G because so many states needed that for their Medicaid payment. So now we're in that kind of conundrum. Do we flip over because some of our states are using the OSA with section G? What do you do? So you're really going to have to be strategic. Who's collecting information when? How did that information roll over to section GG? Do people understand the changes? And again, we'll talk about this in detail tomorrow. And then there were some other coding and mapping changes. In fact, I read an article, I think it was from APAC, and where it's talking about the Parkinson's changes. There were 3 different codes that are introduced. So here's the tip here. If you have a cheat sheet that you're using with ICD-10 codes, you better update it. Don't use codes from last year unless you verify that they're still valid this year. Otherwise, you're gonna have some problems as you're trying to transmit your MDSs. And then the last point here, again, some of the states are using the OSA. It's amazing that states have kicked the can down the road for 4 years, and they're still kicking it down the road when it comes to Medicaid case mix index calculations. So if you're in a RUG state for your case mix, make sure that you understand the OSA, what it takes, that you are triggering it and collecting that information, doing it correctly, and that you know who's responsible for it. Does it surprise you, Megan, that we're still dealing with section G 4 years after it was supposed to be gone?
It surprised me. No. States, of course, wait until the last minute to make a decision. So no, not surprised.
There's a lot riding on it, but
Like you said,
kick the can down the road. Okay. The other reminder, and I talked to you about the new REI manual and the new MDS. If you're one of those people who downloads the REI onto your laptop, make sure you load the new one on your laptop and start using that as of October 1st. Personally, I always download the link to the page and then I'll just click on the link for the new REI manual. That way I never have to worry that I'm on the right one or whatever. So please, please, please update your link, update your manual, make sure you're ready for October 1st. Okay, we already talked about the state optional state assessment. You know, the interesting thing is that the OSA manual and item set were released yesterday. So updated. So I've put the link there and we're good with that. So if you have any questions, you know, the thing that we'll continue to talk about is CMS provides tools. They provide tools. And so when there is a manual, you should be reading the manual because that's the rules of the game. So that's that whole thing that we really focus on is go to the source, not necessarily the resource. A resource would be your regional, resource would be the MDS nurse in the facility. Go to the source first, understand the program, the rules, and then use your resources appropriately when you have other questions.
No rules of thumb.
No rules of thumb.
Because Mark Hyder says so.
I hate rules of thumb. Don't know them. Know the rules, not the rules of thumb. Okay. Again, talking about CMS resources. There's some great videos, and those of you who took the time to watch the training videos that were released, I believe in May or June, they were very thorough. The interesting thing is when CMS had its live event, they almost read word for word what were on the videos. So I don't know that you got a ton more out of attending that, but They are thorough. The rules are there. Some of the other videos have been updated as well. And it's not always a change that triggers them to update. I believe it's the BIMS video where they updated and there was no change to the BIMS per se. They just updated the training video and made it a little bit better. So click on those resources, use those resources. Don't let them go unused because they really are quite good. Let's talk a little bit about what's going on in the industry. And we know this, you know, baby boomers by the year 2030, I believe, all of them will be eligible for Medicare. All of them. So whether you call it the silver tsunami, the great wave, whatever you want to call it, it's coming. And here's the thing we have to remember as an industry, there are limited resources. And this was a huge workforce generation. So the workforce is kind of going through a dip, which means tax revenue, those sources that are used to fund Medicare might dip, as well as the demand will swell because this generation is hitting that age. So we have to be mindful, we have to be responsible stewards of this program because we want to provide care. We want to stay in business. We want to be available to this generation as well as any generation to provide care. So we've gone through this before, the march towards value. And some of these are a little bit out of order. You know, we had OBRA in 87, the Impact Act of 2014. QRP and value-based purchase came before RUGs, but all of these things are really pushing us towards getting the right outcomes and saving money. Now, I'll be the first to say I think it's overkill. You know, we have one on top of another, especially with the QRP and the value-based purchase, but they are directed at keeping people out of the hospital, getting better outcomes, completing our assessments and getting the functional outcomes that we're supposed to get, that we should be getting. Whether you agree with the way they do it or not, that's what they're driving towards. And here's the thing, our role is to provide that care, the better care. So even though we're talking about rules and regulations now, I always like to go back to, why do we do this? It's about the care first, the care first. Even when people are looking at their quality measures that are driving their QRP and their 5-star and their value-based purchase, the only way to fix those is provide better care. It's the only way to do it, because if you deserve the scores that you get, the only way to fix it is provide better care, which means focus in on your issues. Then we document the care that we're providing, and then we code from that. Now, right now, documentation is so critical because we have that 5-claim targeted probe and education program going on. It's mandated, and some facilities are already in a TPE, so apparently they're exempt because they're already going through it. But every single facility in the country that thought they were small enough to fly under the radar or thought that they just don't get targeted, they will be, and we're already seeing those trickle in. We're seeing them trickle in. So that documentation, very, very important to support your coding, because that's all that the auditors will have to go on. So be really mindful of that. But it goes back to the care. Care first, document that care. We code from that documentation. Now, I'm sure you're asking yourself, what keeps Mark up at night? What keeps me up at night? Well, I told you, it's those overlapping measures. It's the QRP and value-based purchase and 5-star and all those things that are wrapped up separately and then smashed together that really cause me concern. Okay, it really is making sure that we understand the programs and we're doing well, because if we do poorly in one of the areas that overlaps, we do poorly in all 3 or all 4 or however many areas it overlaps. It's a compounding penalty, if you want to call it that. So lots of stuff always cause me concern about new measures. Do we understand the new measures? And then information collection versus benchmarking. You know, that concerns me. Is the government really just watching, or are they getting ready to make a change that's going to impact our payment? And generally, it is they're going to benchmark, and there's going to be either a penalty or reward attached to whatever they're benchmarking. So some of these changes that we'll talk about that aren't necessarily effective for reimbursement or penalty immediately These are things you should be watching because it takes a while to get them in place to make sure that we are doing our jobs. And 5-star, again, when I think of 5-star, I always think it's public facing. It shows what the government is telling the public about us. And it's interesting how few providers look at their 5-star. It's updated quarterly. You should be going in there and you should look at it. And I realize survey environment's tough. It's tough. Staffing is tough. Quality measures, for the most part, are manageable. You should be managing those things. I'm not saying you shouldn't staffing and survey, but they're tougher to manage. But you should be watching and you should know what your quality measures are. You should know what your weaknesses are, because the current generations go to the computer first to Google everything to find out what you are, what you can do. The other thing is more and more payers are going to the 5-star measures and saying, can you be included in our system? Yes or no? If you're below a 3, no, you're not. And you can say, but we're good. Look at what people are saying about us. Doesn't matter. You're not a 3 or star higher. So pull those things, pull them into your QAPI, make sure that you are accountable for what's being seen out in public.
All right, so we're going to talk about the SNF Quality Reporting Program, one of the many 3-letter acronyms that CMS has given us, also known as the QRP. And so a little background here, in case you're new to the QRP or aren't really sure what it is. The SNF QRPs pay for reporting program. So SNFs that do not meet the reporting requirements are subject to a 2 percentage point reduction in their annual payment update, which is the APU, another 3-letter acronym. The reporting requirements involve data elements in the MDS that are used to calculate long and short stay quality measures and outcomes. So with the fiscal year 2024 SNF PPS final rule, CMS made several changes to the SNF QRP. We've got 2 new measures. They removed 3 existing measures, modified 1, and then, of course, increased that reporting threshold, which we'll talk about. All right, so one of the measures adopted into the QRP with the final rule was the discharge function score measure. So the discharge function score measure calculates the percent of SNF residents who achieve a risk-adjusted expected function score at discharge using self-care and mobility items from section GG of the MDS. So basically, we're looking for the resident to have an observed discharge function score in section GG items that is equal to or higher than what CMS's expected score was. There are, in addition to GG items, there are several risk adjustment factors to account for differences across residents that affect their functional status. So we're looking at variables like their age, their admission function score, the primary medical condition category, did they have surgery prior to admission, what their prior function was and what devices they used. Do they have pressure ulcers, cognitive function, continence, communication, nutrition? Like there's just a whole lot of stuff that they're going to use within the MDS to calculate what they think, and when I say they, I mean CMS, what they think the patient's expected discharge function score should be. So we're going to talk about a couple of the other measures that are being removed a little later, but this measure is going to basically replace the admission and discharge function assessment and care plan that addresses function measure, which is currently in the QRP. And as Mark was talking about just a few minutes ago about, the shared measures across programs, this discharge function score measure was also adopted into the VBP within that 2024 final rule.
Yeah, and I actually like this one. I think the last measure of just checking the box, was it done? Just seems silly. It wasn't meaningful. The reason I like this, and you'll go through this next slide, is we're working on these things and it aligns with so many of the other programs. We should be able to do well at this.
Right. Yep. So this is just a quick look at the section GG items that are going to be used to calculate that discharge function score. They've got eating, oral hygiene, toileting hygiene, roll left and right, lying to sitting, sit to stand, chair, bed to chair transfers, toilet transfers, walk 10 feet, walk 50 feet, wheel 50 feet. So we've talked a lot about getting a good baseline regarding such section GG. If you've attended the last several webinars that we've done, there's really no difference here with the discharge function score measure. It'll be, super important that the teams get the patient's true prior level of function and accurate function upon discharge, along with all of those variables that we just mentioned on the last slide. And that will allow for an accurate risk adjustment and an accurate calculation of that expected score.
The thing, I want to go back to one of my comments about crossing over. These should look very familiar to you. Each of these items should look very familiar because they're related to physical therapy PDPM payment, occupational therapy PDPM payment, nursing PDPM payment, now the SNF QRP, and the value-based purchase. So most of these items are included in at least 5 ways that you're getting paid. We should pay attention to these. We should be expert at these.
All right, so this is just a picture, basically. I don't know what else to call it. It's a photo. So Acumen was is the company that CMS contracted with to develop this functional outcome measure. So this is their technical report. I think it's only like 26 pages. It's not super long, but it has all the MDS items that are going to be used in calculating that expected score, as well as the calculation of the measure itself. I kind of stopped paying attention to it when I got down to like the math that had the letters, and I was like, I didn't pay enough attention in like statistics or whatever. So if you want to go read it, we'll have a link to it. But like I said, it's not long. If you're interested in reading how they came up with the measure, this is what you're going to want to dig through.
Absolutely. I think it's important also as we're working towards the right outcomes. Don't worry about the exclusions. Don't worry about the covariates. Don't worry about all those things. Focus on getting the right outcome with your resident. The rest of the stuff will work itself out. But this is a really good resource and it is pretty compact. So.
All right. Another measure adopted into the SNF QRP is the COVID-19 vaccine % of patients who are up to date. This begins with the fiscal year 2026 SNF QRP. And in the final rule document released at the end of July, it states that they intend for this to be an MDS-based item, which sent off alarm bells in my head because I thought maybe I missed something in the final item set of the MDS that's going into effect in October and in the draft RAI manual. But guys, there's not a question for COVID vaccinations in what we have now and what we expect in October. So the draft technical report for this measure did confirm that while this item does not yet exist on the MDS, it will be added and collected at the time of discharge. Again, that draft MDS item has not been finalized, but in the technical specifications for the measure, it does show a picture of what they would want it to look like. And it just basically says, is the resident up to date with their COVID vaccinations? Yes or no? That's it. With the pneumonia vaccine and the flu vaccine, we get other options for coding that. Was it offered and declined? Is there a medical contraindication? With this one, nothing. It is a yes or a no. And another thing about this particular measure that I find interesting is that in the final rule, there were several commenters that, really had a lack of support for this measure because it didn't have any exclusions. So basically CMS said they want raw data on vaccination rates. So if they excluded any residents, it would distort that intent. So it is a simple yes or a no, but Medicare A only. So they're excluding a lot of patients while they try to not exclude a lot of patients. So
interesting stuff. At some point, the MDS is going to be as long as the final rule if they keep adding stuff.
Great. All right. Core Q. Nope.
Not today, Zerg.
Not today. So the one proposed measure that was not adopted into the QRP via that final rule was the Core Q. I read through all the comments. The comments And the response from CMS was the most entertaining part of the final rule for me. And I haven't read all of it yet, but I really enjoyed reading the comments and seeing what people's perspective was on all of these. But basically CMS said they decided not to finalize that core Q measure, but that they remain committed to the timely adoption of a meaningful measure that addresses resident satisfaction or resident experience. So there will be this or something like it in the future.
Yeah, I agree.
Absolutely.
Agree.
All right, so what is being removed from the SNF QRP? There are 3 measures that are going away. First is the what we talked about earlier. So that application of percent of long-term care patients with an admission and discharge functional assessment and a care plan that addresses that function. Basically, CMS cited that the measure performance among SNFs was so high and like you said, it was a checkbox, you know. The performance was so high, there were really no variations of the performance across facilities. So it just wasn't meaningful anymore. They also indicate that the discharge function measure is more strongly associated with those desired functional outcomes. So they're going to get rid of that one. Also going away are those outcome measures, the change in self-care and change in mobility score for medical rehab patients. And kind of along the same line, CMS just said they believe that the cost associated with this measure really, you know, didn't outweigh any benefit. So they're going to get rid of all 3 of those.
Might as well, we're getting a new discharge function score, so might as well.
Yeah. I don't want to duplicate efforts for once.
Yes, yes.
For once. All right, so a couple of modifications. CMS is going to modify the COVID-19 vaccine coverage amongst healthcare personnel, beginning with fiscal year 2025's program. This tracks the percentage of healthcare personnel working in SNFs who are considered up to date with their COVID-19 vaccinations. Here's the kicker though, in accordance with the CDC's most recent guidance. That has changed quite a few times. So that's going to be the kicker. The prior version of this measure only reported on whether that person had received that primary vaccination series. This modification requires the SNFs to report cumulative number of personnel who are up to date. I use up to date in air quotes. Yeah, so with both COVID vaccination measures, you know, the accuracy of the data reported just relies super heavily on what the most recent guidance is from the CDC. We got to always stay, you know, up to date on what the CDC is saying is up to date for COVID vaccinations.
Absolutely.
All right. To me, this is one of the most important changes for the QRP program. So there's going to be an increase in the QRP reporting threshold. Currently, 100% of the qualifying items have to be completed on at least 80% of the assessments submitted to CMS. Beginning with calendar year 2024, that 80% is going to 90%. There's a potential penalty 2 percentage points on that annual payment update at stake here. So if your facility is ever flirting with that 90% line or gets anywhere near it, or gosh, if you're below 90%, you need to take a deep dive into what items are being dashed, because you really need to satisfy that completion requirement on this threshold to not lose any more money. Can't afford it.
And this is a one to watch very closely, because the deeper you get into the year, the harder it is to reverse that trend, because the number of MDSs reported is so big by the time you're into the middle or end of the year. A lot of times you can't correct that once you notice it. So constant vigilance.
Especially those facilities that are a little bit smaller.
Oh yeah.
You know, it just hurts a lot more. So that change happens calendar year 2024, impacts fiscal year 2026. So if everything I said on the previous slide had your head spinning a little bit, I want to explain a little bit further how you can check your threshold status, see if you're passing or not. So in iKeys, or if you use another program to pull your Casper reports, you can request a report called the SNF QRP Provider Threshold Report. You can run it anytime, and as a general rule, I always run it for the calendar year to date. because that's what CMS is looking at. We're looking at a calendar year at a time. And then just look at that percentage of assessments that were submitted complete. Like on this sample report, they're at 96%. 96% starting in calendar year 2024 will be passing. But I want to be like 99, 100. Are there going to be times when you need to dash something? Yes. It's supposed to be rare, but there are times when you just don't have the information. So really pay attention. Pay attention to that percentage threshold and whether you are passing or whether you are getting close to 90%. So when we're talking about the QRP threshold, we've typically only been concerned with a couple of those sections on the MDS, and it's of course a huge no to dash these items. Talking about section GG, we've got K with the height and the weight, section M with the pressure ulcers, and then section N with that drug regimen review. They are adding a lot more items to the threshold. So, like I said, we know that the REI manual tells us that CMS expects the use of a dash to be rare, and I agree with that. The intent behind the MDS is to assess those patients comprehensively, get, as much information about their functional status and their strengths and weaknesses, so we can provide the best quality care that we can. In order to do all of that, we need documentation, right? So CMS is basically telling us with these updates, you must get all of that information. You must document that information, and it has to be coded on the MDS, or else we're taking 2 percentage points back from you on that APU or annual payment update. So now we're looking at a bunch of new items on the MDS. So as of October 1st, these items will be on the MDS, and you better be completing them, or you are at risk for that 2%, 2 percentage point reduction. So I'm not going to read through all of them. In the link on the bottom of this slide, you can go directly to the table that has all of the MDS items. I just, in the interest of space on this slide, I just put what the items were, but all of the actual items and their item letters and numbers are on that table.
Great.
All right, so how do we know what patients are potentially counting against our threshold percentage? So what items are being dashed? This MDS 3.0 error detail report, I feel like, is one of the most underutilized CASPER reports that we have. There are a million, when we submit a batch of assessments to CMS, there are a million different like warning messages and error messages that you can get. There is one particular error message, it's 3897. And when you run this error detail report, if you select only that message, it will spit out a list of, within that time frame that you selected, it will spit out a list of all the patients, their assessment ID numbers, what the error message is. So, hey, you've dashed this item and you are at risk of a payment penalty. It also tells you what the item was in the MDS. So you can go straight to that source, check that source documentation. I see a ton of heights and weights dashed all the time. That counts against you. So double check, make sure that you have, a height and a weight on your patients, so we don't have to dash those things. Of course, section GG, section M and N, and all of those new items that I had listed on the last slide, those are going to be, really what you want to pay attention to. But this report is a great way to double check yourself and go straight to that source. Make sure you have that documentation, and then, if you can modify that assessment, do so as appropriate. All right, so real quickly, CMS is going to begin publicly reporting on the transfer of health information to the provider as well as to the patient with the October 2025 Care Compare refresh. If your facility does not have a process for documenting that a reconciled medication list was given to the patient or the subsequent provider, that is your homework. Every single thing we put on the MDS has to be backed up and insured by source documentation. This is a huge one. How you get this information and where you document it, completely up to you, but it has to be documented. So this will be a new MDS item in section A. Data collection begins with discharge assessments on or after October 1st of this year, coming right up on it. So time is of the essence for this one.
Okay, let's talk a little bit about value-based purchase. Now, Fortunately, like we talked about, some of these areas cross over. So this is going to be a little bit shorter discussion. But one of the things I want to remind you about the SNF QRP is that right now you're being rewarded or penalized based on the DASH reports.
Oh, you're
But-
asking me.
No, you are.
Oh, I was
You
like,
are being,
is
I
it
was- that was dramatic pause. That was a dramatic pause.
I'm like, wait, I missed something.
However, you can see all these other measures that they're placing on there that at some point are going to impact payment. So you cannot ignore those, and everything Megan talked about is extremely important. So SNF value-based purchase, same way. It's been based on rehospitalization, but as of the next couple of years, it'll be up to 8 measures that they're tracking. And so each one of those could potentially and probably will impact patient payment. So we know there are 4 new quality measures. They're replacing 1 quality measure. There's several policy changes. Like I mentioned at the beginning of this webinar, the nursing staff turnover measure has been added to the value-based purchase. That's one of the things that they've added to make sure that we are staffing adequately. Now, we know that a lot of states already have regulations wrapped around staffing and staffing requirements. They look at that during survey. This is just another layer on top of that. Just want to make sure that you're very aware of it. That discharge function score will impact you here. So that list of those ADL, the ADL and functional measures will impact your value-based purchase. Long stay hospitalization measure per 1,000 resident days now is a new measure. And value-based purchase used to be almost exclusively, in fact, it was exclusively a short stay measure for traditional Medicare Part A. We're now seeing 2 long stay measures, that and the percent of residents experience 1 or more falls with major injury. Now, obviously, a fall with a major injury is a terrible thing. And we certainly don't want to ignore that. We'll talk about it in a minute. But again, the nursing staff turnover is something you'll want to be very conscientious of. It's the same measure they use for your PBJ. So you're already collecting this information. If you're doing well with your PBJ, you should do well with your value-based purchase. But it's in addition to the total hours per resident day staff or total nursing staff that we're already using to affect payment in 2026. So layer and layer, staffing. What are you doing to engage your employees so that they want to stay? Got to retain. Discharge function score, we're not going to go through it again. Meaningful, want to make sure that your programs are focused on those items that are measured. So when you're talking to your therapy, you might want to talk about their sitting to lying, their transfers, their walking or wheeling 50 feet, doing those things that will be measured. Those are the things you should be actively working on in your plans of care, not just therapy, but on the nursing and sometimes in your activities departments as well. Active activities, it's a good thing. Your hospitalization measure per 1,000 resident days for your long stay residents. So how often are they going to the acute care hospital, the critical access hospital, or outpatient observation days? Those count in this measure. So treating residents in place, that really is what this measure is about. Falls with major injury. Like I said, this is a really big one because it also impacts a lot of stuff. 5-star, QRP, value-based purchase, crosses over. The other thing is the morbidity and mortality rate of those who fall, especially with hip fractures and those serious injuries, is really high. It's a very traumatic thing to our residents. That's always our first concern. The second piece is it takes a long time for these to drop off your quality measures. Forever.
Sandlot.
Eh,
Forever.
Exactly. So those administrators who say, hey, we need to fix our quality measures and we're going to fix this. And then the next month they say, why hasn't this changed? Well, it's not going to change for how long?
Forever.
Yeah, forever. 275 days. It's not going to fall off. And if you have another one, it's not going to fall off for 275 days. This is not something to take lightly. The place where we find the most errors are nurses that are checking that J1900C as a major injury, and it wasn't. It was a severe injury, was not considered a major injury. So in order to be checked here, it has to meet the criteria. It was a bone fracture. It was a joint dislocation. It was a closed head injury with altered consciousness. It was a subdural hematoma. And if it doesn't meet one of those, it's not checked. And that doesn't mean you don't care plan it and document it accurately. You always do that stuff, but it won't show up in this area unless it meets one of these 4 criteria. So very important, very important. If you have any questions, please review this with your consultants, review it in the REI manual, make sure you understand it completely. We are replacing the skilled nursing facility 30-day all-cause readmission measure. It's phased out in 2028, and there will be a skilled nursing facility within state potentially provincial readmission. Awful acronym, awful way to say it, but it really will be their calculation of what's preventable. My guidance is work on your rehospitalization rate. Don't worry about all the qualifying criteria. Treat the patient appropriately. Have your physicians engaged and your non-physician practitioners like your PAs and your nurse practitioners. What can you do to appropriately treat them in place? That's your key. Again, this is about the potentially preventable readmissions. You have your timeline, your performance year. It will impact you in the 2026. So please, please, please pay attention. They're measuring it, and it will impact you. Another one is the health equity adjustment. And I'll be honest, I've listened to a lot of training, as I'm sure a lot of you have. I've not heard a lot about this. And this is really more geared towards your admission. What type of admissions are you taking? If you have 20% or more of dual eligible residents, meaning they are on Medicare and Medicaid, you're going to score higher. And there's going to be incentive. With the value-based purchase, the government used to withhold 60% and then redistribute, or they would redistribute 60% of what they withheld. They will now be redistributing 66% of that. That additional 6% will help accommodate those facilities that have a higher number of dual eligible residents. So just an admissions thing and something to keep in mind. Okay, with all that said, we're going to fly through this stuff pretty quickly. I know we have about 5 minutes left. We talked about a lot of things. What to watch. It kind of goes back to what keeps me up at night. Those things that overlap, okay? Falls with major injury, your section GG scoring, your discharge scores, all those things, your QRP, your value-based purchase, not the core Q yet, but your resident satisfaction better be in the forefront because it does impact your surveys right now. It impacts your admissions, and it will be something that CMS is measuring in the near future, according to them. So what do? We make sure that our teams understand the changes, that they know the rules. One of the discrepancies that we see is there are a few people in the facility that understand what's going on. The rest of the clinicians and people working in the facility are doing business as usual. Well, if one group's playing checkers and the other's playing chess, it's a terrible game. Make sure people on the floor know what's going on and that your processes have changed to accommodate the CMS changes to make it easy on you, to make it easy on your teams, make sure that you're successful. One of the things that I'm really going to encourage, and when we meet with the leaders next week on the 22nd, we're going to be talking about these things. What do we need to do? We need to make sure we're allocating time. Time to make changes, time to change processes, the education, the mentoring, the equipment, adequate staff. Time is usually my biggest issue. It's my biggest concern because it's what we're least likely to give to accommodate to changes. So please, if you're a leader, you're listening to this, make sure people have the education, but also the time they need to plan, implement, follow up, do those things that are going to allow you and your teams to be successful. So I always go through this, and this has to do with the rules of thumb. The rules of thumb. Don't follow the rules of thumb. Don't listen to somebody tell you they know all the rules. Go back and read the rules. There's so many great resources. You can start with the final rule in the Federal Register. You can go to any of the nursing manuals, the CMS manuals that are online. You go to your professional organizations that have written extremely good summaries of the changes. CMS put out a very nice summary of the changes. Go to those things, use those things. The other thing to remember is there are manuals for almost every single for every single program the government puts out, without exception. Read the manuals. Understand the rules. Understand how to run a successful QRP meeting, because you can't make changes in the quality of your care and measurements of that care unless you understand how the care is being measured. The manuals will tell you that, okay? They'll tell you that, so use those manuals. Constantly ask, are you providing the right basics and base for your team? Super important that the leadership, and that means nurse leaders, that means the CNAs that are really opinion leaders, that means your administrators, your social workers, they are really providing that foundation so that you can have successful change. Otherwise, you're going to really run into a brick wall. You're not going to have a team on the same page. So again, this kind of phrases what I just said. One of the other pieces I always go back to is right in that left-hand bottom corner, who does what by when. You need to make assignments. You need to follow up. You need to have backups and backups for your backups. Think about how many people come in on the weekend. Think about how many times somebody's out on vacation. They're out for a personal day. You need to have backups that work, okay? Now, last poll question.
All right, my process for collecting and coding section GG using an IDT approach is, you tell us, very good, good, okay, not good.
Score yourself and be honest.
Might be
Amy, do we have that poll up?
It's already deployed. So I thought that maybe one of you did it. Let me try again.
Oh, that's strange.
Just 1 second.
That's all right.
All right.
There you go. Answer away.
Thank you,
Yeah.
guys.
Come on, be honest, people. Be honest. You have 5, 4, 3, 2, 1. Stop it. Okay. Looks like okay is the biggest group. Not good. If you put not good and okay together, yeah, make sure this is a focus. And we're going to be working on this tomorrow during our webinar. So please spend time with us then. Really look forward to spending that time with you. A couple of other things really quickly. And we do provide at QRM some excellent MDS oversight services. We have an awesome team of very skilled nurses that really provide a high level of support and expertise that we welcome you to explore. QRM also provides several other service lines, in-house rehab management, multi-claim contractor audits, support there. Ashley and her team are excellent, as are the marketing and our branding. So if you have any interest in those, please let us know. We also have links to our events and presentations, podcasts, which cover a lot of these same topics, and we invite you to enjoy those. Unfortunately, we're at the hour. Thank you for spending time with us, and look forward to seeing you tomorrow. Amy, we'll turn it back over to you.
Thank you, Mark and Megan. Another fantastic presentation. And as Mark mentioned, we will be flipping the tape to side B tomorrow. So it will be the same time, just a different link. So we really hope that you can join us. Mark and Megan will continue their discussion and share advanced techniques for facility IDT collaboration. Once again, thank you for joining us, and we hope to see you tomorrow. Bye-bye.